So I take over because Dr. Borderie is sitting in his hotel room and he has to leave that obviously in half an hour. And so we just changed the two talks. Can we see Professor Borderie? Yes, hello.
Hello, Bertrand.
Vincent, how are you?
Fine,
Comment allez-vous, monsieur?
Très bien. Dankeschön.
So I would like
thank
to
you so much.
I would like to introduce Professor Borderie from the Centre Hospitalier National d'Ophtalmologie in Paris. Professor Borderie received his degree in ophthalmology at the University Hospital Center Paris in 1994, where he trained as a resident and received his PhD in 1997 in the specialist subject of transplantation. He holds his professorship in ophthalmology and the position of chairman of the Department of Ophthalmology at the Centre Hospitalier de Paris since 2000. Since 2013, Professor Borderie is head of the Inter-University Diploma of Cornea. In addition, Professor Borderie is chairman of the Clinical Research Group at Sorbonne University and leader of the Cell Therapy Platform Institut de la Vision at the University Paris. His specialist areas of expertise and research areas are anterior segment surgery, transplantation, corneal diseases, ocular infectious diseases, corneal stem cells, and imaging of the anterior eye segment. Vincent, we are looking forward to your lecture on infectious keratitis, diagnostics, and therapy. Thank you that you could make it in a live version.
Thank you so much, Bertolt. And I apologize for not being with you due to pitfalls in travel destination name. One later makes a difference, so that I will make my presentation from the wrong Homburg city, which is probably a poor copy of the original. Well, when we deal with infectious keratitis, and I will show you how we do in my institution, which is the French National Eye Hospital, we have to think about epidemiology. For instance, in France, we have approximately 50,000 viral keratitis a year for 5,000 bacterial keratitis and only 100 fungal and acanthamoeba keratitis. However, as is said in the morning, there is an increase in the incidence of fungal keratitis. And in addition, what we found in France was that there is an increase in the frequency of contact lens wear and filamentous fungi, which are the most severe forms. When we manage infectious keratitis, we need a full corneal workup, including slit lamp photos, spectral domain OCT, and IVCM. With those exams, you can assess the size of the ulcer, infiltrate, stromal necrosis, inflammation, and with IVCM, you can visualize infectious agents which size is larger than 1 micron. Of course, virus first. Most of viral keratitis are due to herpes viridae. You saw the different species. And the epidemiology of herpetic disease is very important. So the prevalence is very high. The incidence increases with age. And the presence of antibodies in tears is very high in the general population. And of course, you know the recurrence rate and the prevalence of herpetic keratitis in the general population is as high as 1.5%. The same applies for herpes zoster ophthalmicus, which is quite frequent, and the global prevalence of herpes zoster ophthalmicus is 4%. Of course, the diagnosis will be clinical in most cases, and you all know very well the different clinical forms of epithelial stromal and endothelial herpetic keratitis. For herpes zoster ophthalmicus, there are some clinical features. such as presence of keratic precipitates, hypoesthesia, dry eye, lid involvement, in addition to hypertonia, high-risk involvement, optic neuropathy, scleritis, or oculomotor nerve palsy. Of course, pain is a very important symptom, and sometimes a VZV PCR can be useful. Lipid keratopathy is a common event in patients with herpes zoster ophthalmicus, so don't miss this diagnosis. In favor of herpetic keratitis, we have the history of recurrent keratitis, the presence of stromal melting, and in some cases, positive HSV PCR results. The diagnosis is most often a clinical one. However, in some cases, such as patients with severe clinical presentation, uncertain diagnosis, or when you need long-term antiviral treatment, then corneal scraping may be useful. Conversely, if you treat a patient with superficial keratitis, which diagnosis is evident and you only need short-term antiviral treatment, then there is no need for corneal scraping. Never forget to assess corneal sensation when you manage infectious keratitis, because with virus, it can lead to neurotrophic keratitis. To manage your patient, you need antiviral drugs, anti-inflammatory drugs, anti-angiogenic drugs, and protein drugs, and you will use them according to the presence of virus growth, severe inflammation, neovascularization, and neurotrophic ulcers. The second group of infectious keratitis are bacterial keratitis. You have a lot of bacteria that can give an infectious keratitis. However, in 80% of cases, you have gram-positive cocci. There are some clinical features of bacterial keratitis, which are an epithelial defect with a unique stromal infiltrate, lid and ocular surface inflammation, in addition to anterior chamber inflammation and superficial stromal melting. This is an example of Pseudomonas keratitis. Here, Propionibacterium acnes keratitis, Haemophilus influenzae keratitis, Staphylococcus coagulans negative keratitis, Staphylococcus aureus keratitis, and nocardia keratitis. When you have a bacterial keratitis, you need to assess severity. Severity is based on presence of Tyndall effect, hypopyon, an infiltrate which is close to the optic axis, with a diameter larger than 2 millimeters, stromal melting, and scleritis. And in case of severe keratitis, the protocol we use is to use wholly fortified antibiotics eye drops. Patients are hospitalized. You use cycloplegia, antalgic treatment, and systemic antibiotics when necessary. Conversely, if it's a moderate or mild form, we use commercially available antibiotics by associating quinolone with aminoglycoside. Of course, the antibiotics treatments should be adapted to clinical response and microbiological results. We have a lot of antibiotics available. These may be commercially available drugs or fortified antibiotics which are prepared by the hospital pharmacy, and we will use them according to the species with suspect or which has been identified by the lab. Hair transplantation may be needed in some patients. For instance, therapeutic keratoplasty to decrease the number of bacteria or in case of perforation, and amniotic membrane transplantation in case of persistent epithelial defect or stromal melting. We have to prevent and to manage corneal scars. So in my institution, we introduced topical steroids as soon as the infection is under control, and the antibiotics eye drops are tapered to avoid epithelial toxicity. Some patients will keep corneal scars, but we always wait for at least 1 to 3 years before making a decision, because corneal transparency can take time before improvement. And depending on the corneal endothelial condition, we will perform a DALK or a PK. When should we look for non-viral, non-bacterial infections? When we have resistance to the antiviral or antibacterial treatment, in case of contact lens wear, in case of propagation of the infection in the deep stroma with epithelial healing and decreased superficial inflammation, in case of an infiltrate with a filamentous or fluffy aspect, and when we have multiple satellite lesions. So the first diagnosis is acanthamoeba keratitis. You know the pathophysiology that starts with the superficial epithelium going down in the deep stroma. There are some features in the clinical presentation: contact lens wear, severe pain, epithelialitis, followed by stromal keratitis with large corneal ulcer, ring infiltrates, radial keratoneuritis, and satellite infiltrates. Conversely, scleritis is uncommon in acanthamoeba keratitis. The disease has to be classified, and we know that advanced stage and a high number of DNA copies are associated with poor prognosis. These are some examples of acanthamoeba keratitis of increasing grade. This is an example of a stromal acanthamoeba keratitis with radial keratoneuritis. And here, a superficial acanthamoeba keratitis, where you see clearly the acanthamoeba cyst within the corneal epithelium. A confocal microscopy is very important for the diagnosis, and we have to know the IVCM images associated with acanthamoeba, which are hyperreflective images that can be round or oval, or like rod or coffee bean. They can be double-walled or with a halo or with the signet sign. They can present as file or clusters, and they can be associated with trophozoite-like images and neuritis. So how can you be sure that it's acanthamoeba? We performed a case control study a few years ago, and what we found was that if you have at least one of the 3 feature images, which are target, cluster or files of hyperreflective images, and trophozoite-like images, then you have a positive predictive value of 87% and a negative positive predictive value of 58%. Our rationale for treating acanthamoeba keratitis: first, co-infections are very frequent. We perform a deep corneal scraping for direct examination and PCR. In addition, we send the contact lens and the case to the lab, and we perform confocal microscopy. And you see the sensitivity of the 3 techniques: PCR first, followed by confocal microscopy and direct examination. Our treatment protocol includes eye drops with PHMB associated with hexamidine, and we use also an antibiotics. We start with 1 drop every hour, then the treatment is tapered, and we discontinue the antibiotics when the bacteriological results are available. We use level 2 analgesic medications in addition to psychological care. This is our algorithm for treating acanthamoeba keratitis. Not so simple. We take into account the response to the treatment, toxicity, inflammation, and so on. The last infectious group is fungal keratitis. It can be due to filamentous fungi, yes, or dimorphic fungi, but in 90% of cases, these are filamentous fungi producing pigments, and mainly Fusarium and Aspergillus. There are features for fungal keratitis. They are rare under mild climates, and conversely, in India, it's 1 out of 2 corneal ulcers. The features are contact lens wear, trauma with plants, the aspect of the corneal epithelium, which is irregular, gray, you may have defects. In the corneal stroma, you have an infiltrate with ill-defined boundaries, multiple satellite lesions, filamentous aspect, pigment, and basically ring. At the level of the corneal endothelium, you can observe an endothelial plaque and anterior chamber inflammation. And last, deep progression with superficial healing is very suggestive of fungal keratitis. IVCM is also very important for the diagnosis. What we observe is presence of filaments, of blezofilaments, which size, diameter, and branching differs among species. And you have to differentiate those images from the subbasal nerve plexus, dendritic cells, and stromal nerves. The sensitivity is high, approximately 90%, and the specificity is between 80 and 90%. This is an example of a fungal keratitis with an endothelial plaque and filaments on IVCM images. Here you have a Fusarium keratitis with multiple lesions and filaments on IVCM images. Here is a filamentous fungal keratitis combined with Enterobacter cloacae and Stenotrophomonas maltophilia infections. This is a Fusarium dimerum keratitis. Here, a Pseudosporium keratitis. Our treatment protocol includes antifungal eye drops. We start with amphotericin B, and we associate voriconazole eye drops in case of filamentous fungi. And for severe cases, we associate caspofungin. We start with 1 drop every hour, and then the treatment is tapered. All steroids are discontinued, of course. Antibiotics are associated in case of co-infection. We use level 2 analgesic medication and psychological care. And we may need systemic treatment with voriconazole or caspofungin, intracameral injection of amphotericin B or voriconazole, intrastromal injection of voriconazole, and intravitreal injection of amphotericin B. Surgery may be needed, for instance, cross-linking, amniotic membrane transplantation, corneal biopsy for the diagnosis, and keratoplasty, PK or DALK, in certain types of cases. So to conclude, I will say that epidemiology is necessary for first diagnosis orientation. Clinical features provide first presumptive microbiological diagnosis. Multimodal imaging is mandatory for diagnosis, for assessment, and for follow-up of patients with infectious keratitis. Acanthamoeba and fungal keratitis, although rare, remain major diagnosis and treatment concerns. And last, keratoplasty is still needed when medical treatment fails. Thank you for attention.
Vincent, thank you very much for this very good overview over the whole spectrum of infectious keratitis. Let's start with a question from Cologne, Sylvia Schrittenlocher. Merci for the nice presentation. Do you have any pragmatic tip for differentiating between viral and bacterial, not acanthamoeba and fungal, with a confocal microscopy? Also, in my experience, the stages of infection is very important because not every infection presents typically as in the atlas from the beginning. What do you think? Confocal microscopy for viral and bacterial keratitis, does it make sense?
Well, with virus and bacteria, you will not see the infectious agents. The only things you will see is inflammation. So you will see round cells or dendritic cells. But it's quite important to look for acanthamoeba and fungi because the lab test may be negative. Because the infectious agents are deep in the stroma, and when you perform corneal strapping, you don't retrieve the infectious agents. So for those severe cases, IVCM is really very important. And as you may have association of bacteria with fungal or with acanthamoeba, or you may have also association of virus with bacteria or virus with fungus. I think that IVCM is very useful, even if you have isolated a bacteria on your corneal scraping.
So you would suggest, as we do it, to use the confocal microscopy on each infectious keratitis, major infectious keratitis, at the day of entering the hospital?
Yes, that's what we do. And I didn't show you, but there are not only virus, bacteria, fungi, and acanthamoeba that can give infectious keratitis, but also aliens. You may have protists. I have one case of Pythium insidiosum. And for these very special agents, IVCM is very useful. So effectively, we always perform IVCM the first day for severe infectious keratitis.
Vincent, what is your attitude about the timing of ashokeratoplasty in infectious keratitis, especially acanthamoeba and fungus? How long do you wait before you become active with penetrating keratoplasty?
Well, it's a very interesting question, difficult to address. I would say that I take time. I try always to give a chance to the medical treatment before going to surgery. I know that in some centers, they would prefer to perform surgery first. For instance, it has been published early dark in acanthamoeba keratitis, but I'm not convinced that this is the best thing for the patient. So we perform keratoplasty when the medical treatment fails. And for those patients with fungal infection, we will perform first cross-linking before performing keratoplasty.
Further questions from the audience here? Jesper, no question? Yes, Jesper has a question.
Thank you very much, Vincent. A little question. Microbiome analysis is something that is being discussed and used and evaluated. Is it something you are looking into when actually trying to make a diagnosis of the bug in keratitis?
Yes, that's an interesting topic. Well, currently we don't really have the data. My personal point of view is that we should use PCR for all infectious agents. I would say PCR first. Currently in my institution, it's not always possible, especially for fungi and bacteria. But of course, if we could have a really broad spectrum PCR analysis leading to microbiomes, that could be very, very interesting. Well, the next question is, well, we have a lot of infectious agents at the ocular surface. And if we look deep, we will find a lot of infectious agents, but do they correspond to the agents that is responsible for the infection? That's a question I cannot answer.
So thank you very much. Any questions? Nothing in the chat. So Marcel, thank you very much for making it possible that we could hear you live